One subgroup of patients with metastatic colorectal cancer that's essentially seems to have used to have many less options and used to have a worse prognosis than most patients is the MSI high. So it's interesting. MSI high colorectal cancer in the metastatic setting confers a poor prognosis, in the early stage setting a good prognosis. And theoretically, the reason for that is, what MSI high does, it builds those mutations into tumors. So you have a hypermutated tumor, which is very inflammatory, and the immune system keeps it in check. That's why most of the MSI high patients with early stage cancers are actually stage 2. For the stage 4, I mean, for disease to metastasize when they are MSI high, they have to really be aggressive enough to overcome the check of the immune system. So I think for that, they may be actually more aggressive. Interestingly, those respond incredibly well to these immune checkpoint inhibitors. And we've seen that first with pembrolizumab, a study that essentially looked at uh, uh, MMR proficient versus deficient colorectal cancer. Zero response in the proficient. In the deficient, the response rate was north of 35 to 40%. In fact, with long-term follow-up, more and more patients actually went from a PR to a CR and more from stable disease to a PR. So that response continued beyond 20, 24 weeks. And in the first study, actually, the PFS was not reached and the overall survival was also not reached. Um, and then after pembrolizumab, and that led to the approval of pembrolizumab. And this wasn't just a study that included colon cancer, but also included non-colon cancers, seeing very similar results. But let's focus on colon cancer. Then came another study, checkmate, with nivolumab or nivolumab plus ipilimumab. And I want to emphasize the or. And that was a choice, that was not a randomization. Oftentimes, I think the study and the way it was published can be very deceiving to the reader, because the curves were placed on the same graphs and figures, which essentially makes it very difficult to for someone who just looks at them without reading the context. They may think these were randomized. They were not. So you were picking essentially who goes on each arm. Those studies did confirm again that nivolumab ends up having a value, very similar value than pembrolizumab, historically at least, in this group of patients. The ipilimumab plus nivolumab seems historically at least to have a higher response rate than nivolumab alone, and a better PFS. We don't know about the survival as much. And interestingly, Heinz-Joseph Lenz presented data with nivolumab and ipilimumab in the first line, which also suggested that you can reach a response rate up to 40 to 50% with a PFS and an OS that were not reached. So what we know today is that we have the option of a PD-1 alone or a PD-1 inhibitor plus CTLA-4 inhibitor. So how do you choose which is the right one for your patient? So we don't have any randomized data. All what we have is historical data. The assumption is always that more is better, which is not completely true. In fact, for about 30 to 50% of patients with MSI high metastatic colorectal cancer, all what they need is the PD-1 inhibitor alone. There is a small percent of patients that may benefit from the doublet, meaning the PD-L1 plus CTLA-4. And we have to keep in mind that although ipilimumab was at a lower dose, it still confers added toxicities, but there's also the significant addition of cost. So we really have to be very judicious about who those patients are. In my practice, most patients will get the PD-L1 inhibitor alone, and typically it's pembrolizumab. So that's the one I've used the most and the longest. That doesn't mean nivolumab couldn't be the one. They probably have equal or similar activity. They've never been compared, so we can't say equal. But they have similar activity historically. Pembrolizumab, historically at least, when we look at the separate studies, seem to have a higher response rate, but I'm not sure that's a fair comparison. And then for some patients, I would choose Nivo plus Ipi. Now, who are those patients where I would choose Nivo and Ipi? Indeed, if response rate is indeed higher, at least historically again, uh, and the PFS is more prolonged, for some of these patients who are younger and have more symptoms, I may actually choose to start them with nivolumab plus ipilimumab. For all other patients, I start with pembrolizumab, and that's going to be the majority of the patients. I start with pembrolizumab, and then if they have a good response, be it, that's all what they're getting. If they don't have an optimal response, I may switch them to nivo plus ipi, and that's going to be a small percent of patients. And for those patients, frankly, that will not respond to a PD-1 inhibitor, it's very difficult to think that a combination of the two will switch a non-responder to a responder. Again, I hope that these studies will be done. I know in melanoma we have some hints about the fact that we essentially don't need to start with an intensified regimen. We can introduce that in the non-responders later, but we need to do that in colorectal cancer to have confirmation whether we indeed would improve outcome if we use 2 versus 1. Today we don't have that, and as I said, we'll go with 1, and then for select few, we'll go with 2.